Oh gosh, wait. Let me introduce you.
Okay.
It gives me an absolute pleasure, great pleasure in introducing Dr. Tapan Mehta. Dr. Mehta, let's do this very eclectic training he's received. So he received his bachelor's of engineering in computer engineering from Mumbai. And then he came over here, Mumbai in India. And then he came over here and did his MS in electrical engineering from the University of Alabama at Birmingham. And then did a PhD in biostatistics, also from UAB. He has been at UAB since then, risen very rapidly through the ranks, and is currently a tenured full professor and vice chair for research for the Department of Family and Community Medicine at our School of Medicine. He's also the director of the Methods and Health Informatics Core, building an innovation in digital health and technology, the Big Data Center for Clinical Research. Holds many other titles, but what I'm really excited, Tapan, is the fact that your research encompasses so many things that we are so interested in our institute. So he's a health services and outcomes researcher, particularly in relation to rehab and cardiometabolic conditions. He uses pragmatic trials as well as analyses of large data. So your research has focused on effectiveness of efficacious and scalable interventions and strategies in the real-world healthcare setting through the application of pragmatic study designs and developing optimized intervention packages. I have to talk to you if you'll have a minute at some point later on in order to talk about research ideas. Incredibly well funded. You just recently received this mega grant on steroids. It's like in tens of millions of dollars. It's optimizing effectiveness of primary care delivered telehealth interventions to manage type 2 diabetes in people with physical disabilities and multiple chronic conditions. And then, of course, like miles and miles of research funding going on and on and on, very well published. And I don't know where you were hiding, but here you are. And we would love to hear your talk today. Thank you so much. Now you can share your talk.
Yeah, thanks a lot, Smita. That's an extremely generous introduction. And I hope my presentation meets the expectations. But I'm really looking forward to sharing the work we have been doing. And let me just first share. But thank you again for the invitation and this generous introduction. Are you all able to see my screen?
Absolutely perfectly.
Okay, awesome. So I think, just a brief follow-up to Smita's very generous introduction. I'm a product of collaboration and some amazing mentors on campus, and really think like an engineer, look at the data like a biostatistician, data scientist, and really excited about finding solutions to healthcare related areas, and that's been sort of my journey. And would love to share what we have been doing so far in the primary care space around that. These are just some disclosures around consulting and the funding I have. Really wanted to again acknowledge the colleagues, staff, trainees from different centers, schools. I've been in School of Public Health, Health Professions, and now in the School of Medicine. And it's been a joy to work with a variety of collaborators, and also in my way through this journey, really understand how we can engage with stakeholders to really enrich our research. And that's sort of where, again, the PICORI funding that we have received recently is a fact that we have been engaging with stakeholders to understand what they would like to see in primary care setting from a telehealth point of view. This is an amazing team that we have in primary care. Not everybody, but the core set of team that are driving some of the projects I'll be describing. And I wanted to really share people make projects, and while we write grants and we conceptualize and build, would not be possible without some of these talented scientists and staff. So I will start with the quintuple aim. When I joined family medicine 3 years ago, it's about exactly a little over 3 years ago, we formulated a research strategy around projects that will support quintuple aim. What is that? That implies improving patient experience, improving population health, reducing healthcare costs, improving provider experience, so clinician experience, and then health equity for all, which is health equity is an important strategic area of focus for our school. So aligning our research strategy also with the strategy that's research focus areas that the school and the university has, but then giving it a very primary care lens. So the population health, reduction in healthcare costs, uh, patient experience again has ties back to value-based care. And we all know we need this over here because of the significantly high obesity rates, diabetes rates, cardiovascular death rates. You can pick a condition and we have a problem to solve here. And that is magnified with the fact that there is a large shortage of primary care in the nation, but especially in Alabama and Deep South. And so that's really what's driving a lot of the research projects as well as improvement science that we are doing. So when we think about the projects that I have focused and we are building a research strategy around are pragmatic effectiveness and implementation science studies, so that we are able to bring and test interventions, comparators that have been shown efficacious or maybe have been shown effective, but we want to test out implementation strategies. We also want to engage in improvement science for learning health system perspective. How do we continuously improve the primary care learning health system over here? And a couple of aspects to the focus areas or attributes I would say is focusing on digital health, trying to create more access, but also how do we build digital health that is effective as well as reduces disparities. Building on the idea of interprofessional care teams. The primary care health system is going through a strategic planning, and primary care is also part of it. And the care team concept is now getting more mainstream at UAB than it has been before. But again, thinking about what care teams would help from chronic prevention and management of chronic disease. And of course, artificial intelligence, how do we really utilize that to improve patient experience, reduce provider burden, as well as to improve population health. When I think about a biostatistician and health services researcher trying to tackle this overall gap or area of research, a couple of attributes that I have prioritized, and I would humbly submit we should, is like causality is on a continuum, right? So the evidence of what is causal, there are many designs one could apply. And so which design is applicable and how do you then weigh the evidence is important. Then focusing on pragmatic study design principles. How do we optimize resources? We are in a resource constrained environment from a health point of view, certainly from a primary care point of view, but also from a I would say now from a research point of view. And so then how do we build studies where we can test things out more efficiently? And then alignment with patients, providers, and payers, engaging them to really understand the research question and the comparators that we are bringing in so that we can diffuse these in the clinics, in the healthcare settings. And just a quick overview of this on causality on a continuum. So as I mentioned, that randomized trials, quasi-experimental approaches, natural experiments, and improvement science, looking at learning health system approaches as well to really continuously improve interventions, programs that can be delivered in the care. From a pragmatic study design principles, why is it important? Really from a making sure it's what we learn is applicable in real world setting. And in fact, for me, the inspiration comes actually from cancer research. When I was in public health, I was working on some of the collaborations with cancer researchers, and I continue to work with some of them, and the idea that research intervention as a line of treatment within a clinic is really important in the concept of what are the studies that we can offer in primary care, such that the clinic time is utilized well, the participant time is utilized well, and we are generating knowledge that can improve the healthcare of in primary care. So that takes me to the idea of then we talked about pragmatic, we talked about causality on a continuum, different designs, natural experiments, randomized trials. Uh, the other idea that I have been really focused on is using this multi-phase optimization strategy. And this comes from some of the work that Linda Collins has done, Bonnie Springs, but we have been in our core really developing some really good studies around this principle, this approach. The multi-phase optimization strategy has three phases: the preparatory phase, optimization phase, and evaluation phase. And the idea is that the in the preparatory phase, we are really identifying the candidate intervention components. We are piloting, identifying what optimization criteria we want to use, and then developing an optimization trial. And I will just briefly go through that in next two slides. But if the optimization phase is a way to test intervention components out in a much more efficient manner. And then from the candidates that got selected for optimization, and then from the ones that got selected from the optimization phase, one can do a large comparative effectiveness phase in the evaluation phase. And it's a continuous optimization principle. Almost, for me, this is natural. Like I really like this framework because also as an engineer, I can think about this as a continuously optimizing approach of a system. So for what does it mean to have a preparation phase? So in the preparation phase, we are really trying to identify what is the optimization criteria. So an example would be, is it cost effectiveness? If we are doing for example, in one of our studies that got funded, the optimization criteria was weight loss, but also participant burden. In some cases, it could simply be the clinical change that needs to happen, but there's a lot of work that can be done in the optimization criteria. One can use techniques such as discrete choice experiments, micro simulations to really build on that concept. Then identify which intervention components do we want to pick. Uh, does it have feasibility data? Does it have efficacy data? Because what the goal here is to build an optimized intervention package. Unlike typical trials where we have bundled everything in one, this is more of engineering a package, intervention package that is optimized for the population that you want to focus on. And then in certain optimization trials, there is also this concept of tailoring variables, of variables that are used to adapt or modify the intervention. In the optimization phase, there are different types of designs. So factorial experimentation, sequential multiple assigned randomized trials. There is also the just-in-time adaptive intervention. There is micro randomization. So there are many designs within the optimization phase. The two ones that we have largely focused on is the factorial experimentation, which essentially allows you to developing programs that are optimized on an average for the population. So if you take the example over here, this example is asking, is which combination of coaching and rewards will optimize the clinical performance that we want to see on an average in the patient population. So that's the factorial experimentation. And then the sequential multiple assigned randomized trials are where we need tailoring variables. So these are the idea is that people start with different treatment assignments, they are randomized, and then some are responding to the treatment. So that's the responder category, and they continue. Some are considered to be non-responders. So there is an assessment done at a certain time point. So let's say it's an A1C, a 3-month A1C is assessed. And if it's not reduced by a certain percentage, then we consider that individual as a non-responder and re-randomize them to intensive interventions. And for me, this framework has been extremely intuitive because it sort of aligns with what I would expect from treatment going from a less intensive to a more intensive, or less costly to a more costly approach, and helps with resource allocation. The strength of most is that because we are using multiple intervention components, so we are decoupling them and building a package, we are able to test these things out using these designs in a very resource friendly way. So the sample size required is less. The time that you would require would also not be, it would be similar, but you are now testing many components. If you had to do this using typical parallel randomized trial, then we would need to do many trials to sort of tease this apart. So it's both efficient from a resource for a implementation of research. And it's also resource friendly from a health services research, that these designs are trying to optimize. Uh, we have to identify the optimization criteria, but trying to optimize the uh, the the intervention package, like which intervention package is optimal for a particular condition. So on that note, let me go through some examples we have. This is a study that is funded through NIMHD within the Health Equity Action Network, which is Forge Ahead is part of the Health Equity Action Network. That is, and it's an optimization implementation trial. And this study came about really when I was Andrea and Gareth were working on the Forge Ahead grant, and I was like, maybe we can build something where we can test how can we optimize these different intervention components that are being tested out in the primary care setting. So when I joined, when I started working with actually family medicine, we were already testing remote monitoring, health coaching, and through some of my uh, collaborations with industry, I knew there was some food box delivery work going on as well with payers during COVID pandemic. So this idea just came about in this conversation of like, let's test out which package would really be optimal to manage diabetes. And so it is again focusing on a multi-level scalable diabetes management, focused specifically on uh, Black adults who have uncontrolled diabetes in the deep south. It's a collaboration between UAB, UMMC as part of the Forge Ahead Center. And since then, we have now included many sites as well. So the next, why, just a little bit about the study to give you a flavor of how this was conceptualized. The concept here is like identifying which combination of these intervention components are clinically effective, and that's determined by 0.5% of A1C change. Identify the optimal combination based on the cost effectiveness criteria. So that's our optimization criteria. And then identifying the contextual factors that affect implementation of the different intervention components. So really thinking about the implementation aspect. So in this study right now, we have over 250 participants randomized, and they get randomized between all of these eight combinations. Everybody gets the primary care like screening visit and then a diabetes education that is done by a certified diabetes educator. And then some get randomized to they get randomized to one of these eight components. The choice of the intervention components was really based on targeting suboptimal social determinants of health. So, for example, digital health coaching addresses transportation barriers, addresses quality of care, uh, provides health services access. Getting access to a primary care provider is not that easy. There's a lot of wait time, and I think navigating some of those aspects is digital health coaching can help. Similar with remote patient monitoring, uh, it provides health services access, quality of care, and transportation. It addresses those domains. I wanted to say that. And with food box delivery, really focusing on food insecurity, access to healthy foods, and transportation issues. So a quick overview of why we chose this. Like the choice of health coaching was because uh, the from a preparatory phase. So, the trial is an optimization implementation trial, but we had to justify why are we going with these components. And so if you think about now from a most preparation phase, there was evidence from health coaching being effective uh, and being done at a very scalable level, working with payers. This is data from Pack Health, which is now bought by Quest Diagnostics. And Pack Health actually provides us health coaching for freedom. Uh, and since then there has been systematic reviews as well as meta-analysis done to show the effectiveness of health coachings and the different types of health coaching. The RPM, Eric Wallace team had already launched RPM for diabetes and hypertension. And UMMC was also doing, in fact, they had already published some of their data using RPM. So again, from a most preparatory phase, it was our case that, okay, health systems, primary care is already engaging in RPM, is already engaging in some places with health coaching. And with the food box delivery, there was a pilot program with an insurer that Pack Health had done, uh, which had shown some really promising results. And since then, they have actually published these findings, uh, and more work has been published in this area around food is medicine, really. So that was our pitch. That was our framing of like why these components need to be studied in the factorial experimentation. This was our inclusion criteria. I would say that when we started the study, uh, I we went with additional inclusion criteria of being on insulin and also having some other uh, cardiometabolic conditions, so like having CKD or CVD. And what we realized is that to make this more pragmatic, and partly it was because of our partnership with UMMC, they had a specific criteria of who can get enrolled in their RPM program. But since then, we really simplified our inclusion criteria to make it more pragmatic. because we didn't have that criteria at UAB for RPM enrollment. And, especially finding patients on insulin who are also having uh, health related social needs. And I think that was just a very challenging thing. It was not applicable. There's some uh, good ancillary data that we have around that, which will help us understand how do you make recruitment and inclusion criteria more pragmatic for these type of studies. So this is just an overview of the study flow. The interventions are for 6 months, and then we have a follow-up period for another 6 months where we are able to do the assessment. The primary endpoint from is the 12-month A1C. So we are looking at the change in A1C from baseline to 12 months. And health coaching that involves 6 months, very clear modules. First 12 weeks are outbound calls, and the next 12 weeks were inbound calls. This was all based on phone, no Zoom, no video calls, and primarily to make it accessible and make sure that the video is not actually a barrier in connecting with the participants or members. Remote patient monitoring, we had to align the remote patient monitoring systems between UAB and UMMC. But again, very standard. There are alerts, and once the alerts go out, there's a protocol that is followed. And the first line of action is for the e-medicine team to really follow up with the patients to check why these readings may be happening and work with them. And afterwards, at UAB, primary care does engage with their patients. At UMMC, it's done more centrally, and I'll talk a little bit about that. Food box delivery was bi-weekly food boxes that were delivered over 6 months with a typical value of $60. I don't know if you all recall, but we still are in a somewhat, some phase of inflation, but this really went out of proportion uh, about a year and a half ago. And it was really hard to work and keep the budget tight of like $60 as the budget, because that also includes shipping, but we were able to work around. And the items in the box are identified by registered dietitians and are meeting ADA nutritional guidelines. So we started primarily by having UAB Highlands Family Medicine, UMMC Endocrinology Clinic, and then UAB Hoover Family Medicine engaged in our recruitment, enrollment, trying to build a workflow where patients' visits could also align with their study visits. And since then, we have increased our uh, reach to Cooper Green, to UAB Selma Family Medicine, and UAB Medicine Huntsville. And I mark asterisks over there to actually also to remind me to really make a point about the impact. So UAB Selma Family Medicine and even at Huntsville, they did not have access to RPM. It was actually we wanting to bring this project over there and launching the builds has created now that e-medicine RPM access setup training, and they are able to refer patients to our study, but also really just engage in routine care where they could use RPM for their own clinical care. Some of the other things we are looking at is, how do we improve the hypertension reach, RPM hypertension and diabetes reach adoption. My trainee Tanjila is fantastic, doing some fantastic work over here, looking at it, comparing the decentralized versus centralized RPM implementations. Again, UMMC having very centralized implementation, whereas UAB having decentralized, and does that change the outcomes? And also thinking about patient preferences, like what would a digital care management program look like? And again, Tanjila is working on her dissertation by using a discrete choice experiment to really study that. That takes me to the next example, I would say, about optimization trial, which is the gamified optimized diabetes management with artificial intelligence powered rural telehealth. And the idea here, this is a collaboration with my colleague Mohan Thirumalai, and we wanted to develop again something that is scalable, where in this case, patients could be referred to a system and that complemented primary care, did not really burden the primary care, complemented the primary care, and just pretty low cost. And so the idea was to study whether gamification can help engagement and adherence, and can we provide health coaching? What would be the differences between AI-based health coaching versus human health coaching? So really trying to uh, reduce the uh, burden on the care team as well by having an AI-powered telehealth coaching. So in this case, we have a broad technology of having automated behavior monitoring calls. These are calls that are sent out through integrated voice response, and uh, all participants receive this call. Data is collected on a daily basis, and then some are randomized to. Uh, so participants are randomized to like these four combinations: human coaching and fixed awards, human coaching adaptive awards, AI-based coaching fixed awards, and AI-based coaching adaptive awards. And the difference between fixed and adaptive awards is patients or participants are incentivized to engage in certain health behaviors to promote those health behaviors. And the question is really, does the incentive to do that needs to be fixed? Is it fixed that works better, or is it adaptive that works better? So giving less incentive early on because people are motivated, but then increasing that incentive over time so that in the longer run, they have more incentive to sort of retain in the program. And so this is a factorial experimentation, but most preparation phase, because we are doing feasibility and preliminary outcomes of these components and combinations, and also assessing the actual usability of the Godard technology. So again, just because it's a factorial experimentation doesn't mean it's in the optimization phase. It's very much in the most preparatory phase, because for us right now, we are assessing the pilot feasibility of some of these things that we are studying. And we just completed the recruitment of all 88 participants for these for this particular study. And we are using Nutritionix API, where we are able to uh, the voice call is used to then transcribe and compute calories consumed, and as well as calories that were expended using exercise. So this is all AI powered intervention. It's not completely AI based health coaching, it is AI supported health coaching. The other example I would give in the most framework is the SMART trials, and over there, some really good work being done by my colleague and close collaborator, Drew Sayer, where we have developed protocols. And again, this paper is out and published. Asil, who is a scientist leading the Freedom study for me, is a first author on the SMART lifestyle. But the idea being, again, we are trying to intensify the intervention. So we start with diet counseling or exercise counseling. And then for each of these interventions, there are non-responders, and those non-responders are then further randomized to more intensive interventions. So this is an example of a SMART trials that has been concluded. This is another example of SMART trial that has been concluded by my colleague and close collaborator, Jeremy Vilroy, who is now in PMNR. And we had published this paper on super health, which was a pragmatic trial on people with mobility limitations. We used the data on that to understand how can we now design a smart trial to really inform what should be non-responders, and how do we then, what component should be we what should be the second level intervention component. So Jeremy led this study, which was based on the work that Jim, myself, Mohan, we all did in using super health data. And the idea being, assessing uh, movement to music intervention with social networking support for 4 weeks versus looking at it at 8 weeks, and then having these criteria of what is considered to be responder versus non-responder. So I wanted to just give you a flavor of this examples, and then there are different comparisons one can do to understand which adaptive intervention is really optimal and it's a very efficient way to uh, study this. I'll move now to uh, this idea of like causality not on a continuum and also the idea of how do we really support quintuple aim. So where does all this fit in? So I talked about optimization trials. Those are to improve population health, reduce cost. Now, this is a center that is funded by CDC, and the goal here is to really have a data-driven center that connects people with disabilities from primary care, but from elsewhere as well to wellness that can be scaled across the United States. So it's an implementation center, a public health approach, and really an example of how health system and public health could partner to really improve population health and in some sense also help primary care from a population health point of view. So we have three strategies here. We have the health screening and referral strategy. We have the health programs, promotion programs, all telehealth based programs. And then we have capacity building. So about how do you increase capacity in uh, community partners in primary care to really provide the care people with disabilities require or need in, and what are the barriers they have. So I think that these are the three strategies that overall NICPAD Connect, as we say, focuses on. And it's a very data-driven approach. Prior to this, NICPAD existed for over 15 years or 20 years, but it was only in this cycle that a data-driven approach was brought in. Prior to that, it was more or less an advocacy center that had a lot of important information for people with disabilities. But now we are really building and diffusing health promotion programs and also evaluating them. So this is sort of the broader map that may help you think about it. We have different sites and referral partners that refer members to NICPAD Connect. They go through an assessment, and almost everybody is invited to participate in this mentor program that Jim and Zoe, my colleagues, they lead this program and many others. But it's a mindfulness, nutrition to optimize resilience program. And then we have other specialty programs that members can also join. And we are tracking. If you see the upper part, there is a data coordinating center that I lead, and with my team members, and my colleague Larry leads the evaluation. Larry Herald from Health Services Administration, close collaborator, leads the evaluation and performance measurement team. And the idea is to really evaluate the mentor program, evaluate how well is NICPAD Connect working, what's the reach of NICPAD Connect, and also evaluate these different programs that we are introducing in the center to support and promote health for people with disabilities. So I just mentioned a couple of things around here, but again, we're using re-aim, we're using the traditional Plan, Do, Study, Act approach, looking at national data sets such as NHANES to compare the data we are collecting with what they have. In fact, our surveys, we built our surveys. Question is to align with some of these national surveys so that we could do these comparisons. And in few cases, we also have EMR data feed to really track our members' long-term clinical outcomes. So we have all those capabilities and also bringing the informatics capabilities we have had and implemented in other studies. Just to give you an example of what our daily workflow looks like, again, looking at the reach and which sites are doing really well. Are there specific areas we could improve? And that's the evaluation that we do, over here using data to even just do pre-post comparison of programs, but also looking at uh, propensity weight or inverse probability treatment weight options to compare those who participated versus those who did not participate, and does their outcomes differ, and then using that evidence more from a causal framework are examples of like causality on a continuum. So the next project I would say, which is just recently funded, Irf and myself and our colleague from UAMS, Laura James, are the MPIs on this. This is the primary care hub that got funded very recently. The former NIH director's capstone project of Care for Health, that is to integrate clinical research in primary care, and our hub's name is Health Enhancement Through Access Research and Transformative Networks. And the goal here is again integrating clinical research in primary care and really driving primary care related research. Uh, we have sites in Alabama, so the UAB Primary Care Service Line, UAB Selma Family Medicine, Cahaba Medical Center has two sites. UMMC is a partner, and then UAMS is a big partner. They have six sites, six rural sites, and the idea is to again support. Currently, we are supporting two studies that NIH has matched, where we help them with recruitment and referral to those studies. One study is an obesity study. It's also actually a factorial experimentation. It's called iReach and funded to University of South Carolina. Delia West and is the contact PI for that, and we are helping them recruit. So this is almost an extension of what we already had. We had a Alabama practice-based research network. This is bigger than that. This is a network of primary care sites for Deep South. And the second study that we are supporting in recruitment is a hearing loss study. And the PI for that is at UA. So NIH actually almost did study dating with hubs to identify which studies could be supported by which hubs. And there was a pretty interesting negotiation process that we all went through. Technically, it's an other transaction, it's not a grant. But again, very excited to build on this because this helps us build infrastructure to support research in primary care. We have done some stakeholder surveys to understand both from the community partners and providers on like which conditions are most important, which topics are most important for them, and really, and this is like a fast-moving project for us. We are only in month 3 of this, but really moving quickly. And in the next phase, we'll be proposing studies. The hubs have been asked to propose new studies. So again, bringing the idea of like bringing the quintuple aim. So why is this important from a quintuple aim? This is important. This hub is important because we all want to do research in primary care, but we don't necessarily have the infrastructure to support. So HeartNet is a mechanism uh, funded by NIH through Care for Health to build that infrastructure to integrate research in primary care. So what does that mean? It means now we should be able to improve patient experience because we are engaging patients also to understand which topics are important. We should be able to improve provider experience because we are through this funding also supporting some of the time that they could dedicate to research, but also identifying ways to bring centralized coordinators who could help with enrollment in certain studies. So the vision that NIH has for this is building a network of networks. And in one could see that if this works really well, one can have rapid recruitment by having studies recruiting across multiple networks, multiple hubs, and really making the studies very generalizable. The last topic I would say I would focus on is our projects, learning health system or practice transformation projects to reduce primary care clinician burden. And we are using AI approaches to do that. So the two areas where we are focused are uh, reducing the provider burden of patient portal messages and reducing provider burden of patient notes through AI-based patient note generation. As some of you may know that there has been a substantial increase in patient portal messages, and our current system actually doesn't allow a good way to triage or classify those messages. And so we received some funding to actually work on this. And Vasil, who is a data scientist and an AI engineer in my team, has been doing some really amazing work on building this, working closely with the health system team members as well in these two areas. And the way we thought about the patient portal message, like now I'm shifting from trials to natural experiments to more of an improvement science approach of, the first approach that was proposed was to just create categories for patients to self-select. And that's what my colleague, Erin Delaney, Vice Chair for Clinical Affairs, actually led that. And those are already in place. And that has reduced some burden for some sites, but not for all sites. In this cycle now, we are working on having the AI-based classification of patient messages into predefined categories so that this can be further streamlined and can align more with how the providers would like to see the classification look like rather than just the patient. And then the next phases would be to, automate certain responses for certain types of classifications and send patient messages that are driven by AI. I think we are further away on that, and I suspect by the time we reach there, we might have epics. So I think this part, the cycle two part, will be done in next few months and will be deployed at least until we all transition to Epic. With the virtual node piece, currently the approach is to really to rely on manual transcription. Actually, it's at least one of the vendors the health system uses. Those notes are recorded and then they go to India, they get transcribed, and it's still a very old uh, approach of doing things. So what Vasil has already developed is an AI-based notes, and the this these two things, doing these two things reduces provider burden, clinician burden, which also means they have more bandwidth to engage in research. They have more bandwidth to engage in helping and thinking about ideas that they could pursue from a uh, pragmatic research point of view and supporting quintuple aim. So I think these are very important initiatives for us for from a and it's part of a strategy to really make sure that we are able to integrate and harmonize our research and clinic clinical missions together. And we are doing some usability testing for the virtual note now, and then we'll be looking at some of the outcomes. And some of the work has already been published in this area by other health systems that are at least few years ahead in this game. But we'll be evaluating again from a data point of view, how does this reduce provider burden, and continuously improving if there are opportunities to do that. That note, I would just to summarize, really thinking about quintuple aim and thinking about projects that really address patient experience, population health, healthcare cost, provider experience, and health equity is important. And I hope I was able to communicate some of it to you. Not just research projects, but also improvement science, thinking about learning health system initiatives in this space to support these activities. And for me, when I think about that, there is what are important research and improvement science questions, the choice of study designs, the choice of technology, how can we test different care teams, developing clinical sites. So we need more clinical sites so that we can diffuse these things. We need more clinical sites so that we can conduct more research in primary care. And then building a model of primary care and public health program partnership, as I showed you an example of NICPAD. So that's really a summary of projects that I have been had a good fortune of working on and leading in supporting the quintuple aim for primary care. And a plug for the methods and health informatics core. We have a fantastic team of folks who can help us with any of your methods and health informatics needs. It is a NIMS funded core, but if you have other interesting topics, then we certainly would want to open to discussing. Cassie is available to sort of first take the intake of the needs. We also have a dissemination, implementation, and community engagement core that my close collaborator and colleague Berta Hidalgo from School of Public Health leads that. So on that note, thank you for your time and really open to any questions you have.
Well, thank you very much, Tapan. I'm opening it up for people to ask questions.
Yeah, I'll stop sharing so that I can see all of you. Is that okay?
Yeah, absolutely. So I'm going to start with the first question that I'm grappling with. You are talking about pragmatic trials. I'll talk about parallel, rigorously designed, randomized controlled trials. Either ways, what is the final step to take it to the clinic as standard of care?
To me, I think, if these interventions have been shown to be efficacious, then the next step is definitely to look at effectiveness implementation, so hybrid trials that one can study. And in certain cases, it could be also done in a very so for me, like there is an implementation strategy question if there are those questions,
Right.
or one can deploy it and then it still needs to be tailored to that setting. So using QI approaches to really build that piece out. And just one thing I would say is like the challenge again is to what can be done in the primary care space, like how much can be done and what can be done by the care teams that support primary care, at least from that point of view. Yeah.
Thank you. Anybody else? Actually, Christy.
Yeah, this is incredible work. It's really cool to see how you've leveraged these different study designs to do pragmatic trials. Since you're about a statistician, I wanted to ask you a broad question about how you think about powering these studies with factorial designs, and if you can give us a sense of the order of magnitude increase in sample size needed, when you add different factors and combinations of interventions, like how should we think about that?
Yeah, it's a good question. So generally, when you add more levels to a factor, that's when you will see the sample size actually increasing in a factorial designs. If you add more factors, uh, the sample size cost is not quite actually as much unless you want to do second order, third order interaction terms. Now, if you want to look at third order interaction terms, then yes, you start looking at higher sample sizes that are required. But the cost of sample size really comes from, let's say in Freedom, we have health coaching, yes or no. But let's say I had designed it as health coaching, yes, human, yes, AI, and no health coaching, right? Now, I went from 2 levels to 3 levels. Now, that would increase sample size requirement. That starts increasing, like that penalty is much higher of increasing the number of levels because now your number of combinations are increasing substantially.
And then I guess the follow-up to that, what about these adaptive trials where you try something and then if you don't get the output that you're looking for, you try something else? Is that helpful
Yeah,
or harmful for in terms of necessary sample size?
I think similar thing applies so that you over in that particular in the smart trial, what happens is really there are a couple of things one can test. One can test is the level one intervention, what are the differences in the level one interventions that are being compared? What are the difference in the level two interventions that are being compared for non-responders? I think you can think about those two as very similar sample size requirements you would require if you're doing parallel arm trials. But when you want to test embedded adaptive interventions, like which adaptive intervention was really uh, uh, better than the other, that's when having these additional components starts making it more sample size. It increases the need for sample size over there. So I would say that for most part, I have seen that part is where you want to plan and you will then require much larger sample sizes to do that. And I also think like for the smart trial, it is probably important to actually look at maybe existing data from an existing trial or do some pilot feasibility before you plan a smart trial. Yeah.
Thank you.
Wendy.
Yes.
Thank you so much for this wonderful presentation. I just wondered if you could comment on the sustainability of some of these interventions. I know it's often a challenge that once you implement something, find that it's effective, but then how do you sustain it in the real world? And in particular, I was wondering on the diabetes trial with the food boxes, for example. And I noticed that you actually measure the outcome at 12 months, but they stopped the food boxes at 6 months. So can you comment a little bit about that one?
Yeah, so it's a very good question. So I think I do think about the sustainability piece. In terms of freedom, the idea was to present data. So the optimization criteria of cost effectiveness is from a health system perspective and to understand whether this is going to lead to improvement in outcomes enough that the payers or the health system should actually cover the cost of food boxes as well. And this is an issue that comes up, like should it be 6 months, should it be 3 months, should it be 1 year, should it be forever? And we didn't have the ability to do all of those things over here, but we have a separate project that we are working with Brigham collaborators where they are actually doing some not a trial, but program evaluation of ongoing food as medicine programs and other components. So I think the sustainability for something like food as medicine program comes from, can we show there is enough evidence for a health system or a payer to cover this? And uh, for example, United Healthcare, Blue Cross North Carolina was covering this as part of helping their members, certain members. And that's how Pack Health started working on food box delivery. So there are some models of sustainability, may or may not be true in Alabama, but I think it's something worth pursuing and generating the evidence. I think the health coaching, remote patient monitoring is a little more achievable. I know over a minute, so I'll just wrap up this quickly. Remote patient monitoring is happening already. It's already being delivered, and those costs are covered by certain payers already. And so if you can present this to Blue Cross and say like this is important, then it's going to provide that evidence. Similarly for health coaching, payers do cover health coaching. And I think the key over there is to keep the health coaching piece and the RPM piece to be cost effective such that it can be sustained even if there is minimal coverage. And that's how we have designed. That's why the Godart was also important. What can be done through AI such that we don't require the cost of health coaching actually goes substantially down.
Thank you so much.
Thank you.
Any others? Well, Tapan, thank you so much. We really learned a lot, and we need to keep in touch so that we can use your expertise and
Well,
collaborate.
thank you so much for the time and invitation. Yeah.
And let's get back to our dreary daytime jobs.
Yes, sounds good.
All right. Bye.